Valve implantation. Mitral valve and ring, types of rings, the good, bad, the ugly. Broadly speaking, we have semi-rigid, flexible and rigid, and they're either complete or incomplete. From the wonderful Valve in Ring or Valve in Valve app, we've got here a semi-rigid ring, 3D Memo, Physio, etc. These have a D shape, but usually circularized with the right valve size choice, and they're pretty much the best target for a valve in the ring procedure, as you can see on the small video there. Next, we have a flexible complete ring, so that would be Durant and other valves. These are marked as intermediately favorable. In my hands, I've had good experience with these in my old center, where they were used quite a lot. But obviously, sizing is more critical. After that, we have an incomplete flexible ring, which on the app is unfavorable, with a small caveat that if you have a prosthetic aortic valve, it tends to support the gap in the ring. So these are cases that can be taken on, as you see in that short video. The reason for that is that the rings will splay, and obviously the more they splay, the less anterior support you have. And then there's the complete rigid ring, and you'll notice I've got no example that I want to show you, because you should avoid these rings at all costs. They're impossible to circularize. If you have one in your hand, you can't compress them at all. They're extremely rigid. You will get trigone leak in both the medial and lateral trigone. You can do things like a double balloon, but then you come across the issue of a large lateral medial distance and a short anterior-posterior distance, and usually after you post-dilate like that, you get a valvulate insufficiency because of the poor coaptation. So, mitral valve and ring, size limitations. The first cut is obviously the deepest. What I would suggest is, if you're having a stenotic patient with a ring, is that you go through the historical echoes and make sure if it's a small ring, that actually what you're looking at is not a fixed patient prosthesis mismatch because of a small ring that's implanted in the first place and failure thereafter. So it's really important to really understand the mechanism. Is this actually a stenosis or is this a patient prosthesis mismatch? There's one small exception to that, which I came across by accident, is the Durant flexible ring, when you have this crinkled appearance. Just occasionally, if you predilate these, ready to do a valve in ring, the predilatation will actually stretch out the ring and reduce your gradient. Although I don't have any data, but that's just hands-on experience. When we talk about outflow tract obstruction, we tend to have an emphasis on neo-LVOT, as we see in the CT scans, but I would really recommend you don't forget the length of the anterior mitral valve leaflet, especially in valve and ring. Often the repairs are sort of a monoleaflet repair where the posterior is almost missing completely, and there's a kind of large, long anterior leaflet that acts as a trapdoor. The problem with those is if the leaflet is long and overhangs the frame, as you can see in this example, which was asked to help him, you possibly have the potential to have a dynamic outflow tract obstruction, which this patient has. And there are no really good ways of treating this. So the way I assess these patients is I look at the worst case scenario. So if I have a neo-LVOT that's on the margin, I'll do a lambda boom. If I have a long leaflet, and sometimes it's difficult to measure the leaflet length because you can't quite differentiate between leaflet and a cordial repair, I'll do a lambda boom, because the last thing you want is to be stuck with a moderate or severe outflow tract obstruction. So that's 200 millimeters or less, and a long MVL meaning 20 millimeters or more. The next thing about a mitral valve and ring is it's nowhere near as forgiving as a mitral valve and valve. The landing zone in the valve implantation is a critical part of the procedure. Here you see the difference between the coaxiality of the ring and where your wire is going to point towards the apex. It's perfectly possible to implant your valve canted within the ring. And that actually means if you calculate it, you need to land your outer skirt on the ring, and you have a very, very low margin, 1 or 2 millimeters. If your outer skirt lies too atria at any point in the ring, then you'll have a frame leak. And obviously if you have an outfit, that can be solved by a valve in valve again, But if you have an outflow tract obstruction, potentially you don't have that option. So, yeah, a critical point with valve and ring. An apical rail can help to direct you with this, and what I mean by an apical rail is just a 6 French sheath in the apex, just to externalize the wire and allow more control. We'll talk about that a little bit later. That allows you to control the cant from the very beginning. But with no apical rail and Edwards system, it's possible to change the depth. 2 techniques. If you're familiar with mitral T-tier, the anterior-posterior movement with the flex allows you to increase or reduce the depth into the LV, clockwise or anti-clockwise rotation. Or there's a push-push where you push on the wire and push on the system together so that you can change the canting. Obviously you have to be careful with the apex and not too rigorous with your push. You have to remember that when you, unlike an aortic procedure, when you push through the septum, you're pushing laterally, you're not changing the depth so much. So generally, if you push, it tends to cant the valve more and lead to a non-coaxial implantation. This is a couple of examples. This is with a safari wire. You see that push there as we're too deep. It doesn't really change the depth at all. It just cants the valve. This is a case from many years ago. That patient ended up with a severe frame leak, but luckily had a wide open LVOT, so we were able to do a valve to solve that problem. The next example is with an apical rail and an implant that went a bit awry. We were able, with the apical rail, the push didn't help, but we're drawing the fixed wire and sheath in the apex. We're able to pull this valve back down into the correct position. And the concept of an apical rail is that you capture the wire and fix the sheath and the wire together at the apical side, whilst it's abutting the delivery tube of the valve. And on the back side, on the groin side, you fix the wire and the delivery system together as well. So whilst your operator from the groin pushes, you can counterpose that push and allow you to correct the cant perfectly. Here you see that in action. Very slow implantation with the cant from the beginning correct. And once you have the cant correct, you can very precisely change the implant depth. Two of that better. Better move on. Of course, apical rail doesn't come without risks. This is one of the, I think this is number 2 I did. I haven't had this problem since. And this won't play. Yes, it will. You need to close that with a plug at the end of the procedure, and there is obviously a possibility of that going wrong. There are some ways of reducing that risk. But on the other side, the commonest failure of mitral valve and ring is malapposition and a frame leak. And sometimes that has no option if it's an LVOT issue. I'm not going to go over the plugging, but I use an ADO 6.4 Amplatz plug with a PCI wire through the middle to act as a backup. And I've done about 40 of these cases with no complications. Briefly, mitral valve and NAP portion with patient frailty. When you think you know everything, you don't. What I would say is you're starting an electrosurgery program, you want early success, don't choose a VMAC lampoon as your first case. Patient frailty is a real issue, 15% mortality at 30 days. It's not just the procedure. Be cautious of selecting end-of-life pathology, which is very common in this group. It's equally as important as anatomical features. And I would say screen those patients out. It's okay to say no. Your therapy is unlikely to help them in the end. Avoiding LVOT. I'm not going to go through the CT, we've seen a lot of that. There are 2 major ways of doing a lampoon, tip to base and base to tip. I don't do tip to base so often now. This is a tip to base with 1 Agilis catheter in the left atrium, 1 retrograde through the aorta, setting your flying V and burning back to a backstop, which is usually a ring or a valve. Base to tip, 2 Agilis catheters, a traversal burn through the base of the leaflet, capturing the traversal wire, forming or flying the burning back. And you can see the idea is to end up with this, open frames that increase your neo-LVOT or skirt neo-LVOT, so you don't get an LVOT obstruction. Here's a quick case, pediatric, unusual case, a young boy that was dying after 4 sternotomies, liver failure, PA pressure of 90, severe mitral insufficiency, a flexible ring with a surgical prosthesis in place, and a very small neo-LVOT, a good skirt neo-LVOT. And you can see here, this is the setup. On the left, we have 2 Agilis catheters. The first catheter has got a balloon end, a catheter through it to put a guide rail to position the snare. And on the right, we've now used that guide rail to put the snare in the LVOT. Obviously, with a metallic aortic valve, you have to be very gentle. You can also do this without the guide rail. The next step is to go to a 3D view. You see to the lateral side is the snare catheter. The one in the middle is going to be the traversal catheter with a JR4 in the middle, clocked, well clocked, and then come into the X plane where you see the catheter bouncing in the middle part of the AMVL. We then do the transit burn. You see the Astato wire through that JR4 catheter through the base of the leaflet at 30 watts cut, hopefully directly into the arms of the snare, trying not to capture any chordae, and then